Okay, welcome to the show. Hey, Dr. Harcourt, thanks for joining me today.
Yeah, thanks for having me on.
Yeah, and for those who may not know, you are out in Santa Barbara, California. Is that right?
Yep, we have offices in Santa Barbara and Beverly Hills. So I enjoy Beverly Hills, but Dr. Perman likes, or I enjoy Santa Barbara, Dr. Perman likes Beverly Hills, so we compromise there.
Not bad two cities to have offices in.
Nice and warm, yeah.
Yeah, especially now as it's the winter's gearing up, but that's okay. Yep. But great, and that is the Imagine X Functional Neurology, correct? Mm-hmm. Perfect. So, Dr. Harcourt, today we wanted to talk about migraine today, and you are one of the experts in our field as far as migraine goes. So I'm really excited to pick your brain and hear what you have to say on the topic. I know you have a book coming out, which we'll talk about later. But before we get into all that, what I'm most interested in is what got you into this field? What got you so interested in treating and helping people with migraines?
So specifically in migraines or more in functional neurology or just everything in general?
Let's do everything in general. We
can get into the deeper stuff. It'll be a much longer podcast than you were expecting. Well, functional neurology was funny because I actually come from a long line of chiropractors. And so my dad and my uncles are both chiropractors. My one uncle is a chiropractor and a medical doctor. My grandpa was a chiropractor. My great-grandpa was a chiropractor. So obviously being a kid, I didn't want to be a chiropractor because everybody did it, right? And so when I looked at different professions, I kind of found out, chiropractic has a lot of what I'd like to do, but let's see how this goes. And so my first week in chiropractic college, I was introduced to functional neurology, and I'm like, that's what I want to do. And it was exciting because it was just a different approach than I'd seen before, and I thought it was neat. And so I've been studying that for over a decade now. And when I got out and we started practicing in Santa Barbara, I had just written a paper that I presented on multiple sclerosis, a rare form of it, and I was doing a lot of TBI treatment. And what I was finding, though, is in Santa Barbara, we have an awesome hospital for TBI, and we also have some really great resources for multiple sclerosis and things like that. But what I kept finding was patients that had migraines, patients that had post-concussion syndrome, patients that had persistent dizziness, they just kept bouncing around all over the place, and we did pretty well with those things at first. And migraine specifically lended itself more to this functional approach. And we originally started doing some, electrical stim to different areas of the face and things like that. And as we got more challenging cases, we added a whole bunch into it. So migraine actually has morphed over the last probably 6 or 7 years, just based on we did good, then we had patients that didn't do good, so then we came up with new things, and it just kind of kept progressing from there. And due to that, it ended up getting me down this rabbit hole of what is migraine and why is it so prevalent, how is it misunderstood, and we ended up finding that in people under 50, it's the #1 cause of disability in the world, #1. In everybody globally, #2 cause of disability. And unfortunately, everybody that I talk to has the same progression. It starts out not so bad, they try some different things, it progresses, it gets worse, and then they're having them every day. And my whole question was, well, why does that happen? How can we prevent it? And that's what the book's about. That's what the migraine program's about. It's really trying to understand the pathophysiology. So regardless of the practice that you have, the type of doctor you are, or even the type of patient that you are, if you understand it better, you can treat it better and be more likely to be migraine-free. And that's kind of the goal.
Absolutely. Perfect. So I feel like in the world of migraine, a lot of people are maybe misdiagnosed, or maybe it's overdiagnosed, or what have you. Just frankly speaking, what is a migraine so that people may, differentiate that from other types of head pains?
Sure. So one of the frustrating things that I go over is right now, the only diagnostic criteria for migraine is purely subjective. So, and it's not just subjective as I have a headache and it's here. It's subjective as, okay, if you have 2 of these couple criteria and a couple more of these criteria, sure, you have migraine. And people that present very different all fall into that same category. And that's a big problem. People that have post-traumatic headaches from a concussion that are diagnosed with migraine fit into that criteria, but don't actually have the pathophysiology of migraine, which is frustrating because you treat it differently. And so true migraine is genetic, which isn't to say that your parents or your grandparents have to have it. It just means that your genes are different from somebody that doesn't have migraine. That's all that means. And what those genetic abnormalities do is they change the excitability, or they change the stability of different pools of neurons or different parts of your brain, and they allow those areas to kind of fatigue or fail. Technically, we call it hyperexcitable, but think of it as failing. And the areas in the brain that are most commonly affected in migraine patients are the ones that inhibit head and face pain. And so when those areas fail, you get head and face pain. And that's what causes migraine. Now, that's the genetic, neurological, that's the cause of it. However, because it's this functional problem, it's this issue with how healthy the brain is, how stressed it is, there's all these different things that make you more likely to have migraine. So, and everybody has different amounts. So some people will have dietary factors that are just super involved in migraine. Other people, it's not as big of a deal. And so one person might try a diet and it changes their life for migraine, and then somebody else does it and it doesn't do anything. Right? It's not that the diet wasn't a good thing, it's just that wasn't their main thing. And so the way I kind of describe it is, if you imagine that the part in the brain that leads to migraine is like a little bucket. When that bucket fills up with all these different stressors and it overflows, that's when you have a migraine. So say your bucket is filled 90% of the way with musculoskeletal stress or tight muscles and joints. Well, if you see a chiropractor, an acupuncturist, or massage therapist, they're going to look like a godsend because they fix most of what's wrong with your bucket. Whereas if that's only a tiny part, it might be helpful, but you might not notice any difference because there's too many other things filling up the bucket. And so what we look at is, A, where's the bucket? Because in different migraine patients, it's on different sides and different levels of the brain, and also affects different areas. And so if you're providing a treatment that was good for migraine patient A, and you do it for migraine patient B, but they don't have the same problem, it's going to look like it wasn't helpful. And so specificity in individual treatment is paramount to migraine treatment. And at the same time, you want to reduce all the things that are filling up the bucket. Because, you know, if you are doing a lot of stuff that's great, but your bucket's really small, or that area of the brain is just really unhealthy, it's going to take a concerted effort in order to see a regression of symptoms. And this is where I see a lot of people go wrong, is they've tried acupuncture and chiropractic and 5 different diets and all these medications, and all those things might have been great for them, but they weren't all done at the same time, and nobody was doing specific therapies to those areas that were dysfunctional. And the exciting thing now is we're actually seeing studies where they're finding, for example, iron deposits in certain parts of the brain that tell you probably have migraine. Or we see these functional imaging changes that you can look on MRI and see differences in migraine patients. So we're starting to get more objective data, but at this point, I find very commonly that if you have a headache and we can't explain it any other way, you just get a migraine diagnosis slapped on you, and that can be very detrimental, as I find. So I find that proper diagnosis and understanding is the most important thing we can do for migraine.
Of course. And I love your bucket theory analogy. That just makes so much sense. And it shows you how individualized migraine can really be and how it can vary from person to person. So one thing is not going to be as effective to one person as it is another. So it really takes somebody like yourself who looks at everything from a multimodal perspective to really figure out what's causing the migraine and how to make the migraine less severe, right? So what are some ways in your clinic that you're able to do that?
Yeah, so we have a lot of different ways, and the cool thing is the more I learn about this, the more I learn of other things that we don't do that can also be very beneficial for migraine. So again, that's kind of my premise is, like, we have a guy down the street that does this awesome nerve decompression surgery for migraine that if that's your problem, he's phenomenal at that. Now, is that everybody? Of course not, right? But if you need it, it's a good thing to know that it's there. In our office, we do mainly non-invasive nutritional, hormonal, musculoskeletal, neurological type treatments that can address migraine in different ways, but we only do it for the patient that needs those things. So for example, I've had some migraine patients that their neurological exam was so rough that the best treatment for them to start out with was lying on their back in the dark, moving their head a little bit while looking at a dot. It's the best thing they could do for them. And I have others with the exact same symptoms that we have them jumping around doing, jump squat exercises and things on a light board to go as fast as they can, because it was more of this cortical issue. They could handle a lot more stimulation, even though the symptoms were exactly the same. And so the therapies they completely depend on the examination. Some of them are simple things like vestibular rehab or gaze stability exercises. Other ones we use peripheral nerve stimulation, so we can actually stimulate the nerves that are involved in migraine. We'll also do things like laser therapy. We're pioneering some new applications of laser that haven't really been used before, which has been really, really cool. And we also do manual therapy, so trigger point work or chiropractic type modalities or massage or all these different types of things. And again, the key is not that any one of those things fixes migraine. The key is they all affect the brain in different ways. And if you can figure out which one's most appropriate for that patient, it's going to be awesome. At the same time, the stimulation also has to be the right amount. So I have some patients that we find the greatest thing ever, and we do too much of it, and they feel terrible, right? It's not that it was a bad therapy, it was just way too much of it. And I see this commonly with massage or with chiropractic, where they got a massage or they had an adjustment, and it was just way too much stimulation, flared up their migraines, and they're afraid of getting adjusted or getting a massage. It's not that it was a bad thing, it was just too much. So there's a lot to consider, but that whole level of activation is very, very important for migraine. And a lot of times it turns people away from doing something that actually would be really great for them. So that's part of what we do with the management of these things long term, is teach people how to understand their symptoms, to manage them, to figure out what's actually a bad thing versus what's just too much of a good thing.
Yeah. And you say manage long term. So what, I mean, everyone's different, obviously, but what's your, I guess, treatment frequency that you see these patients for, and what should they expect as far as prognosis? I mean, generally speaking.
Yeah, it's a great question. And that's actually part of what we're collecting data-wise right now, is we're trying to figure out, how much better do people get? How long does it last? How many medications do we reduce? And so we've been collecting that just recently, the past maybe 2 years, and we're trying to get long-term data on people. But overall, what we tend to find is for people, because we treat a lot of people from out of town, for those patients, I like to treat them with nutritional, hormonal stuff remotely, and then we have them come to the office, and we'll do shorter treatments where we might see them multiple times a day for a week or so, and that's where we do most of the neurological rehab. But what we give them to do at home are things that they keep up with on their own long term, right? And then we'll just follow up with them every once in a while, get them connected with a practitioner that makes the most sense for their case. So sometimes it's an acupuncturist, sometimes it's a chiropractor, sometimes it's just a trainer, right? Because they just need physical exercise. For people in town, we like to spread things out and do everything at once. So I might see them for a couple weeks, right? Maybe 4, 5, 6 weeks. And then my goal of care with everybody is to see them as little as possible without a regression of symptoms. So if you're having 20 migraines a month, and after 4 or 5 weeks we get you down to 2 a month, well, that's great. It's not completely better, but 2 versus 20 is not bad. And if we keep you there for a little bit, well, I might see you every 2 weeks, every 3 weeks, every 4 weeks, and say I see you, in 3 months. Well, after 3 months you start to flare up a little bit. I might see you in 2.5 months then. So again, most of what I find with the follow-up of care is not even necessarily the treatment that we do in the office. It's typically that out of all the things that fill up the bucket, something's kind of slipping quite a bit, and just getting them back on track typically gets them back to where they want to be. So whether that's just staying active or eating half decent or staying away from things that can flare them up, those are all things that we find manageable-wise. So again, usually short-term treatment, and then as little as possible after that.
And I love that, because we don't want people to necessarily be reliant on us just like they would be reliant on a medication. We want to solve the issues so that they're able to live their lives uninhibited by anything and not needing anyone.
Yeah, and that's the tough thing with migraine is, a lot of things we treat, there's an injury and then you rehab the injury and they get better. With migraine, we know there's a genetic predisposition. So those areas, they are forever not going to be as strong as other areas in the brain. That's just how it is. But if you do all these things and understand your condition by itself, you can go months or years without migraine, even though you're still susceptible to it. You're just making sure that phenotype or that expression of the genes doesn't happen. So that's most of what we try to teach here, is controlling how you go about your day and how you go about dealing with the migraine. Because, if you know that a margarita is going to flare up a migraine, but you want to do it anyway, at least you know, right? It's much different than just trying to guess why you have a migraine today versus 3 days ago.
Mm-hmm. And in the beginning, you had mentioned that a lot of people, the migraine kind of progresses over time. Are there any maybe lifestyle factors or maybe traumatic events that may happen in someone's life, maybe physical, mental, whatever, that might accelerate the onset of migraine?
Yeah, absolutely. And not necessarily the onset. That can be trauma, absolutely. But typically the progression can be accelerated quite a bit from traumatic events. So the most common ones we see are people that started off when they're younger with, migraine here or there once a year, every couple months or so. And then they get to college and, you don't sleep a lot, you might go out a little bit, and all of a sudden, the migraines go crazy. The other one, interestingly enough, is after childbirth, not necessarily the first one, but the second child, we see a huge increase in migraine in people for, I'm sure there's plenty of different reasons. We don't know exactly why, but we know that it's common. And then any wildly stressful events. So obviously, death of a close family member, divorce, anything along those lines can really accelerate these things. And then any type of trauma, so concussions, car accidents, anything that puts more stress on the nervous system is going to raise the probability of migraine. Again, it won't cause it. And this is where there's a lot of confusion between post-traumatic headache or concussion, like headaches after concussion, and migraine. They're very similar in pathology, but the post-traumatic headache, even though there's that excitability issue, it's because of a trauma, and it will start to normalize if you treat it over time. Whereas with migraine, you already have that excitability issue. The trauma just makes it even worse. And so, again, it increases your likelihood of migraine. So they are a little bit different. So from a treatment standpoint, I'm more concerned about diet and hormones and things like that in a migraine, whereas with post-concussion, it's not as probable that those things are going to be an issue, even though they can be. So, those are all stressors we see very commonly that create the snowball effect. And interestingly enough, we also see that as you get a migraine, so say you had one twice a year, once you start getting them, every month, twice a month, usually more than about once a week, the actual migraine itself makes you more likely to have another migraine, which is infinitely frustrating. Mm-hmm. And so if you start getting more than one a week and you're having to take the abortive medications and you're, not able to move as much because you're down and out with a migraine, that's where it starts to snowball. And so I like to find people and treat them before they get to about 2 a week, because after that, that's where you have to attack it very comprehensively, which is most of what we do here. But if you can catch it in that, 4, 5, 6 a month category, they're going to regress to, no migraines or very few migraines relatively quickly. And so those are really fun to turn around.
Yeah. What would you say the most common question you get from these migraine patients is?
Oh, that's a good question. Man, I get a lot of common questions. Actually, funny enough, that's why I wrote the book, mm-hmm. because I found, so this book's been about 3 years in the making. And originally it was just because I literally came home one day and I was like, I feel like a broken record. I'm saying like a lot of the same things over and over again. And so a lot of it has to do with what's actually happening, right? Why have I tried 15 medications and they're getting worse? Why is it that I did this diet and it didn't do anything for me when it cured my best friend or whatever? And so because there's been this disparate understanding about what migraine actually is, it's been really hard for people to grasp what the heck is going on with them, right? And we see this even from a practitioner standpoint, myself included. What I thought migraine originally was is not what it actually is, and so that's really changed my approach to it. And when you think, say you're a chiropractor and you adjust somebody with a migraine and they get better, well, that's what you got to do to fix migraines, because they've tried all this stuff and I fixed them. Well, in reality, if they've already done the diet and the nutrition and the stress reduction, all this, and the last piece was the musculoskeletal, well, sure, you're going to look like a miracle, right? But if you see another migraine patient and they've done none of those things and musculoskeletal is only a little piece, well, now it's not going to look like it's super helpful. So which is it? Is it helpful or not helpful? And the reality is they all have the possibility of being wildly helpful, but again, it's individualized. And so that just explaining migraine so that people understand what's actually going on, I find that I get the most feedback that that's really, really helpful, because it makes people feel like they're not shooting in the dark as much anymore, and they have a more comprehensive idea of what's going on. And so I don't know if that's the most common question, but that's the most common thing that people tend to be appreciative of, is just understanding what's going on.
Yeah, absolutely. And have you found that the majority of other practitioners out in the field are literate or are aware of what's actually going on in migraine, or is everyone kind of taking an antiquated approach from what you've seen?
It tends to be the latter. And again, it's not for lack of trying, because if you go on a literature review and you look up migraine, there's 40,000 papers, right? And so I don't know anybody that has the time to read through that. And so what ends up happening is, if you're a medical doctor, for example, they're very well versed in the new CGRP medications or the Botox treatments or all these different things, which again have their place and can be very, very helpful. But again, going back to what is migraine, this is also why with Botox, for example, I see very commonly it can help out short term, and then as they go longer and longer, it works less and less and less. They have to get it sooner and sooner and sooner. And if you look at the pathophysiology, it makes perfect sense that that's how it would go. Whereas something like a topiramate or a medication that's meant to decrease neuronal activity, it makes sense that a lot of our patients tell us that they feel dumber, or they feel like they can't memorize things, or they feel like their cognitive demand goes down, because it makes sense with the pathology. And so what I find is the people that are even experts in migraine tend to be experts in their application to migraine, not necessarily migraine in general. And my main point was, I think we need to have a lot more general migraine practitioners, because the thing that I keep finding more and more is, as I understand this better, I also understand my limitations and where I'm not helpful and where I can't be beneficial to somebody. And in that case, it's really good to know that there's this surgery available, or there's this medication available, or there's this other physical modality that I am not trained in, or any number of things that I'm not an expert in. But understanding the pathophysiology, then I understand which one of those practitioners makes sense. So instead of saying, go see 50 people, I can say, you know what, in your case, this eye doctor over here that has this, crazy sight sync stuff is going to be awesome for your case because of what we're seeing on your exam. And so I hope that we can get to where there is a general practitioner for migraine that doesn't necessarily do everything, but knows where to start and knows kind of the progression of care. And that's what I'm hoping we can get to.
Absolutely, because if you're well versed in all these different aspects of care, you can better triage these patients to find the most appropriate care. And if I can plug your course right now, I actually just started your migraine course. It's really great so far.
Thank you.
And I feel like that's definitely what you're trying to do in your course. And, I would highly recommend that.
Thank you. Yeah, and that was the one of the exciting things for me is getting to just basically be forced to comb through the research. And again, it really forced me to change how I looked at it and how I practice. And honestly, it's almost bad for business, because I end up referring so many people out at this point, because I'll do their exam. It's like, man, this is not where we need to start, or there's really other things you should be doing. And but like I said, for me, I feel like my philosophy on migraine is, most of these people I've seen have spent ungodly amounts of money, have been to 50 practitioners, have been dealing with it for years and years. Who cares if I get them better? If I get them to the person that gets them better, we end up, getting people back. We get people healthy, and that's how we tend to get referrals, is from people that are happy with it, even if we're not the ones that necessarily did it. Now, the way it ends up working is we're usually the last person that they see after they've seen everybody, so we tend to end up doing really well with those patients. But again, that's what I'm trying to avoid, is so that I don't get you 20 years down the road, so that I don't see you after you're to 20 migraines a month. I want to see you when you're at 2 a year. We can say, do these couple of things, you'll be fine, right? Whereas once you get to the 20 or the 30, it's intense, right? It takes a lot to roll the snowball back up the hill. Mm-hmm. And that's what we want to try to avoid.
Right. And I think that's very important, because one of the statistics that stood out to me from just the start of the course was the average migraine patient spends, $14,000 per year on
the upper quartile. And if you've taken more than 2 medications, preventative medications, the average annual expense, whether it's for loss of work or visits to the hospital or medication, is about $18,000 out of pocket, which is insane. Yeah. It's insane. And especially for the interventions that tend to help out, they don't cost anything close to that, right? Yeah. And so if you can save somebody 30 years of paying $15,000 a year on care, I think that's a good way to go.
Yeah, helping people on multiple fronts.
Yep.
So when is your book coming out again, and when can people expect that?
Never soon enough. Yeah. So like I said, this is my first book, so there's been a long process here, but we actually just got the ebook version sent to us like 2 days ago, so we'll probably make that available shortly. But the hardcover, turns out the lag time on printing a book over the holidays is a little longer, so the estimated date that we're going to deliver and be able to send it out is mid-January. So we are taking pre-orders at my website, adamharcourt.com, and that's where you can find it and be updated. But we're trying to get it out there as soon as we can, but definitely by mid to end of January.
Great. And it sounds like you're answering a lot of common questions that you get in the clinic. What else can people expect to look forward to in the book?
Yeah, I get a lot of questions about different types of migraine as well. So, things like hemiplegic is actually one of my favorite types of migraine to treat. I love treating hemiplegic migraine because we tend to find it does really, really well, especially using the principles that I discuss in the book. Things like vestibular migraine, ocular migraine, all these different things, abdominal migraine. These are all different manifestations, and I just kind of talk about how it's the same type of pathology, just different parts of the brain. So we kind of explain how that works, what areas are involved, what you can expect there. I talk a little bit about nutrition. I go over the genetics. And the way the book's actually structured is hopefully interesting. We'll find out. But the way that I did is the first half of the book is very flyover big picture, right? It's still a little complicated, but generally I think everybody's going to at least get the gist of it. And I had a great illustrator come in, and we spent probably 2 months just trying to make illustrations that make this easier to understand. So there's a lot of pictures and stuff in there. But the first 5 or 6 chapters are all, what is migraine, what's going on, like what the heck is happening? Because again, that's the main concept I'm trying to get through. Whereas the last half of the book goes a little bit more into detail about some of the neurological dysfunction or autonomic issues or things that maybe doctors might be a little bit more interested in, but shouldn't be wildly confusing to, say, a migraine patient that's been dealing with this for quite a while. And so the other thing is I kept the book relatively short. So it's not, 800 pages. I think it's about 150 pages. And so it's not something that's going to take you months to read. And that's on purpose because we're basically distilling thousands of papers that we use in the course that I teach and that we've used over the years. We're trying to distill that into just a very consumable way to understand migraine. It's not a textbook. It's nothing like that. It's just meant for patients that have it to understand exactly what's going on and find somebody that can help them out. And for practitioners, regardless of their background, to say, okay, here's what's happening. Here's my way that I can apply that principle to migraine and hopefully help more people than we did before. And so I'll be interested to see if people like that format or not, because unfortunately, as we know, the research changes constantly. So the second I said the book's done, I already had things I want to change on it. So I'm sure, in a couple of years down the road, I'll have a second edition that addresses a lot of those things.
Yeah, I can't wait to use that as a resource here in the clinic for patients.
Good.
Yeah. So one last question. We're just about out of time, but I wanted to leave on this note. I wanted to know if you had any final words of wisdom and hope for A, patients, and then B, other practitioners that may be struggling with migraine.
Sure, for both of them, and mainly for the patients. The fact is that almost everybody I've ever seen has tried 50 million different things, and that doesn't mean we have the magic cure. But the reality is we see a lot of people get a lot better even after trying everything. So my parting words is always look for the next thing, because there is something coming out. There's new research all the time. There's new applications. And, this is why we've put the program together that we have, is we're trying to make the most comprehensive treatment available. And as new research comes out on medications, on procedures, on different things, we also know about that. So again, there are things to look forward to. There are things you can do. just because you haven't found the solution yet doesn't mean the solution isn't out there. And that's really, really important. For practitioners, I've heard so many people say they hate treating migraine because it's so nebulous. There's so many different things that can go into it. And the idea of the book is to at least put something around it and say, look, most of what's happening is within this sphere. And if you do some of those things, great. Here's a good way to go about it with migraine. And if you don't, say you know nothing about hormones, well, find somebody in your town that's awesome at hormones and make sure you send them to that person so that they can get that type of treatment as well. Again, I think if we can just look at this from a comprehensive perspective, regardless of your background, regardless of what you do, I think you're going to just be able to treat people better. And that's the goal. So very optimistic.
Great. Awesome. Thank you very much. That was perfect. So just once again, for everyone listening, can you just share how to find you and your clinic and your book and your course, so people can find out more about you?
So the book is at adamharcourt.com. So you can find the book there and pre-order there. The information about the office is ixneuro.com, and that has information with both our Beverly Hills and our Santa Barbara location. And we didn't get to talk to this, but through the course, we actually I got to do the research on all the different nutritional things that were helping with migraine, and contacted a random company and said, hey, can you shove all this in one product? And they said, sure. And so we're going to have a product coming out soon, probably mid, again, to late January, that will basically have everything in it that's been shown so far to help with migraine, instead of trying to try things piecemeal. And so that you'll be able to find at adamharcourt.com as well once that comes out. So really exciting things coming up in the future.
That is really exciting. Well, thank you.
Oh, and also at Migraine Doctors, sorry, I forget, at Migraine Doctors for Instagram as well. That's where we communicate most of the time. So Instagram is the greatest way to contact us at Migraine Doctors.
Okay, very nice. All right. Well, thank you for sharing your wisdom and knowledge on migraine. This has been really great for me, and I know that for those suffering with migraine, it's going to be a great resource for them as well. So thank you very much.
Thanks for having me. I appreciate it.
Of course. Enjoy the Santa Barbara sun.
Good luck with the snow.
Thank you. All right. Have a good one. And this has been your host, Dr. Coppus. Be well.